Hi, everybody. Again, it's Dr. Al Hewer. We're going to be covering the second batch of review questions for the ACCS exam. So let's actually dive right into this. There's questions 26 through 50, and then we have a last batch that's actually questions 51 through 76. So we threw an extra bonus question in there as well. So let's take a look at question 26. Which of the following is not recommended for critically ill patient with signs and symptoms of fluid overload? Initiate diuretic therapy, A. B, restrict and closely monitor fluid intake. C, administer steroids. And D, if renal failure, consider dialysis. The correct answer is C, administer steroids. This is a little bit of a subtle topic here, so let's look at the explanation. Pretty important. Systemic steroids have a lot of potentially deleterious effects. But let's look at this particular one that's not probably not as well understood as others. So management of patients with fluid overload normally includes restriction of fluid intake, administration of diuretics in critically ill patients, insertion of a central venous pressure catheter, central line, to closely monitor fluid balance. If heart failure is suspected, inotropic agents, they would increase the squeeze of the heart and cardiac output, may be considered temporarily. If renal failure is a contributing factor, dialysis may be initiated. However, corticosteroids tend to cause sodium and fluid retention and should be avoided in such cases. So steroids are used for a whole abundance of disorders, systemic steroids. But if you think back, and they can be wonderful drugs, including the steroids that are administered for patients that have apparent respiratory effects from COVID. So they can be very, very valuable tool, if you will, or very, very valuable class of medications in our arsenal for a host of diseases. But they're not without their downside. Downside is they can decrease our immune response, cause Cushingoid syndrome, weight gain, excitability, diabetes, a whole host of things. And this is another one that you can add to that list as well. Question 27. A physician requests a spontaneous breathing trial, SBT, for a patient managed in assist control mode with Pavilon or pancuronium bromide. Which of the following agents should or could be administered to reverse the effects of Pavilon? A, pentothal. B, levophed or norepinephrine. C, succinylcholine or nicotine. D, neostigmine. The correct answer is D, neostigmine. Let's take a gander at why. Since pancuronium bromide is a competitive blocking agent, its action can be reversed by giving a acetylcholine esterase. Okay, so that's an enzyme inhibitor, such as neostigmine or pyostigmine. Question 28. 28-year-old, 80 kilogram, 175 pound approximately, male trauma victim with a closed head injury is receiving volume control AC ventilation, has been paralyzed with Nimbex. The ventilator settings and current ABGs are as follows. Let's look at the vent settings. And let me just pause before I go down the rabbit hole of the vent settings and the blood gases, is when they give you the weight of an individual, 80 kilograms, 175 pounds, and they don't tell you height, they don't tell you any other information, they're not saying that they're obese, whatever, you should assert, for the sake of taking the MBRC exams, that this is approximately the ideal or predicted body weight. So that's a caveat here. Let's go back to the vent settings. The mode is volume control AC. The tidal volume is 700. Rate is 12. FiO2 is 30%. PEEP is 5. Blood gas 7.36, so low end, but still within normal range. PaCO2 40, smack dab in the middle of normal range. Bicarb 22. PaO2 is 63, and the SaO2 is 92%. Based on this information, you should recommend which of the following. A, raising the PEEP to 10 centimeters. B, increasing the tidal volume to 1 liter. Sounds a little, I mean, we might have done that 30 years ago. C, raising the FiO2 to obtain a SAT of 100%. And D, increasing the mandatory rate or decreasing the mandatory rate to a rate of 8. Let's look at the correct answer. Raising the FiO2 to obtain an SaO2 of 100%. Okay. Before I go into the explanation, I will, I promise. But if you're looking at PEEP, PEEP is not a terrible answer. Okay. But this patient also has a closed head injury. You want to be kind of careful with the use of PEEP with closed head injuries because some of that pressure can be transmitted north of the border into the brain in the form of increased intracranial pressure. Okay. So not that you wouldn't do that, but notice the FiO2 is only 30%. Okay. So you clearly have room to go up. So let's look at the more formal description or explanation. Goals of ventilatory support with patients with closed head injuries, or there's many, many goals. But again, the first one, maximizing cerebral oxygenation. Assuring good patient ventilator synchrony. 3, avoiding techniques and settings that could decrease perfusion or raise intracranial pressure. In general, this means aiming for SaO2s of 100%, PaCO2s of 35 to 40, and again, a little bit debatable, folks. Okay, so depending upon where you work, they may actually aim a little bit south of there. They may aim for, 32 to 34, 32 to 35, something along those lines. It's controversial. It's controversial because in causing cerebral vasoconstriction, so hyperventilating your patient to achieve a PaCO2, a little bit south of 35, while it will achieve some vasoconstriction, it will also reduce cerebral blood flow. So it's controversial. For the sake of this argument, we're going to go with the low end of normal range of 35 to 40. And avoiding hypercapnia and a PIP less than 30. Thus, in this case, the first action would be to raise the FiO2 to attain a SAT of 100%. Patient-based ventilator synchrony, it does not appear to be an issue. There's nothing here to say that that's an issue. Patient's paralyzed. Raising the PEEP might decrease cerebral perfusion. Increasing the tidal volume is just, that's a distractor, if you will. Plus, it's really not indicated because the patient's ventilation is good. No longer recommended as a maintenance strategy for these patients. So decreasing the rate would cause, hypercapnia and elevate ICP potentially. Other therapies, including osmotic diuretics, is an option. Cerebral spinal fluid drainage and sedation are also generally included for ongoing management. From the MBRC, you can almost undoubtedly expect a question or two related to head trauma and ventilator management for them. Question 29. Patient admitted to the emergency room is spontaneously breathing, but comatose due to carbon monoxide inhalation. He has a PaO2 of 87 torr. Remember, that's what's dissolved in the plasma, and a PaCO2 of 36 on a torr or millimeters of mercury on room air. Which of the following actions would you recommend? A, administer as high FiO2 as possible. B, initiate mechanical ventilatory support. C, administer continuous positive airway pressure. And D, initiate aerosol therapy with 40% O2. The answer is administer as high FiO2 as possible. Let's look at why. The objective of O2 therapy for most adults is to give sufficient oxygen to maintain a PaO2 between 60 and 100. The exceptions are those conditions in which O2 carrying capacity of the hemoglobin is impaired. Anemia is one of those conditions, particularly where you have a hemoglobin that's in that 7 to 9 range, where it's not just a little low, it's very low. The other category would be carbon monoxide poisoning. Are two of these conditions in which high PaO2s are needed to increase dissolved O2, compensating for the deficient hemoglobin transport. If available, hyperbaric therapy is another viable consideration as well, but it's not a choice in this case. Question 30. Data for a 78 kilogram, 172 pound patient receiving ventilatory support with 12 of PEEP are as follows. Vent settings, AC volume control, tidal volume 550, rate is 8, FiO2 is 50%, the PEEP is currently 15. The PEEP is currently 15. Blood gases, pH is 7.36, PaCO2 is 40, bicarb is 22, PaO2 is 155, the SAT is 99. Which of the following changes would you recommend at this time? Lowering the tidal volume, A. B, increase the rate, C, decrease the PEEP, D, decrease the FiO2. Decrease the PEEP. Acid-base balance are normal, so no change in ventilation are indicated. In terms of oxygenation, the PaO2 is excessive and should be lowered. Either decrease the FiO2 or decrease the PEEP, lower the PaO2 back to normal. When two changes could achieve the same goal, always choose the one that will cause the least harm to the patient or will benefit them the most. In this case, the FiO2 is safe level, but the PEEP is potentially, so they should therefore look at reducing the PEEP. Patient with emphysema receiving volume control ventilation develops signs of air trapping. The doctor does not want to switch to SIMV. Which of the following actions would help resolve this problem? A, decrease the length of time available for exhalation. B, increase the preset frequency of breathing by 30%. C, increase the length of time available for exhalation. And D, increase the inspiratory time by decreasing the flow. Let's look at the correct answer. C, increase the length of time available for exhalation. Why? Air trapping, also known as auto-PEEP, intrinsic PEEP, during positive pressure ventilation is most likely when there's insufficient time for exhalation. Although IE ratios of 1 to 2 or 1 to 3 are generally sufficient to ensure complete exhalation, patients with normal lungs, lower ratios, and just to be clear on this, what we're talking about lower ratio, a ratio is like a fraction. So a lower ratio, 1 to 4 is lower than 1 to 3 or 1 to 2. So in this case, we're talking about lower ratios, 1 to 4 or 1 to 3 may be required in some patients with severe COPD, particularly ones who have emphysema. Emphysema is a loss of elastance. The lungs tend to have very high compliance. They tend to be saggy lungs, if you will. So they will often need additional expiratory time. Alternatively, small amounts of machine PEEP, so 50 to 80% of the measured auto PEEP level can be used to help overcome auto PEEP. You can also fitz around with your tidal volume. You can fitz around with your rate. The problem with that is you're also going to be changing your acid-base balance. So if the patient happens to also be, alkalotic on top of that, then could you work the rate? Could you work the tidal volume? Yes, and that will by default, reducing the rate, reducing the tidal volume will actually leave more time for exhalation, but you will be changing ventilation. So very, very careful with that. Question 32. After weaning and extubation, a patient on a cool aerosol mask at 40% develops moderate hypoxemia and hypercapnia with a falling pH. Which of the following actions would you recommend at this time? A, increase the nebulizer oxygen concentration to 60%. B, apply bi-level positive pressure via mask. C, administer 50 milliequivalents of bicarb or sodium bicarbonate. D, reintubate and apply volume control ventilation. Volume control ventilation. Let's look at the correct answer. Apply basically BiPAP, bi-level positive airway pressure via mask. Let's look at why. BiPAP is a good option to help avoid reintubation of patients who develop mild to moderate hypercapnia and or hypoxemia after extubation. It is also used to help avoid intubation of COPD patients requiring ventilatory support for acute on chronic conditions, to treat CHF, cardiogenic pulmonary edema, short-term application, 3, manage airway obstruction, central sleep apnea for the nocturnal mainly option. An alternative for post-extubation mild to moderate hypoxemia, where there's not a significant amount of hypercapnia, is use of high flow nasal cannula. A word of caution, and this really is not just from a clinical perspective, but also as it relates to taking the MBRC exams, is it's generally good not to wait too long. So if you're extubating a higher risk patient who's is as a resolving exacerbation of CHF, has a resolving acute on chronic, respiratory condition, generally speaking, so they're higher risk, they may be headed towards a trach, good idea to actually have the device there. In the case of a lot of the latest generation invasive ventilators, a lot of them can do BiPAP. The trick there is to convert them over. It's going to take 5 or 10 minutes to actually get, it's going to take a few minutes at least to get the machine, once the patient's extubated, into the mode, et cetera, and get the mask set up and things along those lines. But besides that, you may not need a new device. You may make, in many cases, you can just use the invasive ventilator that you had. Just best not to wait too long. Question 33. Patient under your care has X-ray and clinical evidence of unilateral right lung infiltrates. His PO2 on a non-rebreathing mask is 55. 55 keeps him alive, but he's got a very low P to F ratio. So the attending physician asks your advice on how to best improve this patient's oxygenation without committing to ventilatory support. Okay, so probably look at this patient, probably thinking of multiple things are coming to your mind. Which of the following would you recommend? Okay, again, you're asked to pick the best choice here. Not, oh, I would do this, this, and this. If that's not there, you got to look at the choices and go with that. So A is place the patient on the left side, basically left lung down. B, place the patient on the right lung down. C, turn the patient from supine to prone. D, institute a regimen of inspiratory resistive breathing. The last answer, the last choice there is really a distractor. So really people who just were like, they fell asleep while taking the exam or something along those lines. Answer A, place the patient on left, basically left lung down. Dependent positioning can improve the distribution of ventilation in patients with VQ imbalances, especially those with local conditions such as unilateral pneumonias. Placing the good lung in the dependent or down position, in this case, left lung, can significantly improve oxygenation without a change in FiO2. Since the down lung will receive the best ventilation, and then we'll let gravity do its thing, and it'll receive, also better blood flow. So you're coming closer to equilibrating the VQ to VQ. Another plausible option is to initiate high flow nasal cannula. However, this is not a choice in this particular answer. If you're thinking of prone positioning, it's not a terrible answer, but we prone patients, as we did with COVID and before and after. It's, we prone patients when it's not unilateral lung disease and it's bilateral. Proning, would be probably the best answer, but that's not the question. The question is that it's unilateral, and the best answer is to have that good lung down. Question 34. Doctor wants a patient de-escalated from ICU to step down with idiopathic pulmonary hypertension to begin self-administering an inhaled pulmonary vasodilator. Which of the following drugs would you recommend? A, epoprostenol or Flowlon. B, Cardizam. C, Iloprost or Ventavis. And D, Tracleer. C is Iloprost or Ventavis. Let's look at why. Pulmonary vasodilators administered with via the inhalation route currently include 3 prostacyclines: epoprostenol, Flowlon, Tyvaso, and Ventavis. Only Tyvaso and Ventavis are approved for administration to spontaneously breathing patients via the inhalation route. Inhaled Flowlon or epoprostenol is an alternative to inhaled nitric oxide therapy and typically administered by a continuous nebulization using IV drip into the nebulizer. Both Cardizam, it's a calcium channel blocker used to treat certain dysrhythmias, and Tracleer, an endothelin receptor antagonist, are used to treat pulmonary hypertension, but are administered orally, so they're not administered via the inhalation route. Question 35. Physician orders intubation and volume control, AC ventilation, for a 6'3" tall, 190 pound, 86 kg, adult male patient with ARDS. Which of the following ventilator settings would you aim initially to support this patient with? Rate of 10, tidal volume 800. Rate of 8, tidal volume of 1200. Even though this gentleman is tall, we don't really use tidal volumes that are approaching or north of a liter. So B is really, just you can almost strike that through. So now you're at least down to a 1 to 3 chance. C is a rate of 20, and a tidal volume of 900, and D is a rate of 15, tidal volume of 500. Tidal volume of 500. Correct answer is D. Let's take a deeper dive. So this question really speaks to knowing the ARDS net recommendations, knowing the use of going as low as actually 4 mLs per kg. You don't necessarily start there, but going as low as 4 mLs per kg in order to keep your ventilatory pressures down and not further contribute to lung injury by ventilator induced lung injury because of overdistending pressures. In adult patients with ARDS, the goal is to achieve tidal volume of 6 mLs per kg of predicted body weight with a plateau pressure of actually equal to or less than 30, preferably equal to or less than 25. If plateau pressures are greater than 30, at 6 mLs per kg, the tidal volume can go as low as 4 mLs per kg, making up some of that, making up the difference in minute ventilation with the respiratory rate, if you can. The respiratory rate should be set to approximately the baseline minute ventilation, as I just said, with the goal to achieve a pH between 7.20 and 7.45. So we actually will tolerate, 7.20 is a little bit low, but we'll tolerate for a period of time 7.25, 7.30. With the whole notion of permissive hypercapnia, hopefully the kidneys can retain bicarb and eventually that the pH will normalize. So for a 6'3" tall patient, predicted body weight of about 85 kgs, the goal would be a tidal volume of about 500 with a rate between 10 and 20. In some cases, rates as high as 35 may be needed to maintain the pH of around 7.30 or higher. Just keep in mind, as you increase that respiratory rate, you may actually be contributing to auto PEEP. So you need to monitor via using an expiratory pause and seeing what your actual PEEP is and your intrinsic PEEP are. And then the other thing is increasing the respiratory rate is a less efficient way to make up minute ventilation because you have proportionally speaking, you have more dead space ventilation. Adults have, crudely put, adults have about 1 mL for each pound of predicted or ideal body weight of anatomic dead space. So for someone such as myself that's just under 5'10", that you can do the math that I have an ideal body weight of about 170, 175 pounds. So if I'm getting a tidal volume of 300 or 350, the first 175 or maybe a little more than that of that is just dead space ventilation. So if you increase the rate, you're just doing more of that dead space ventilation. So it's just something to kind of keep in mind. Question 36. Although treated with several dysrhythmic or antiarrhythmic drugs, a patient with ventricular tachycardia begins to exhibit hypotension and decreased consciousness. Which of the following actions would you recommend at this time? So a ventricular tachycardia is indeed a shockable rhythm. They talk about stable patients with VTach and unstable. If a patient stays in VTach long enough, they're going to become unstable. They're going to become, their consciousness is going to be affected. And the longer they're in it, the harder it is going to be to get them out of it. And eventually, many of those patients with ventricular tachycardia, unless it self-resolves and they just throw a salvo of VTach over, let's say, 5 seconds, something along those lines, and it self-resolves. If they stay there long enough, it can easily degrade into ventricular fibrillation. So it's really important to get on top of this patient very quickly. So which of the following actions in this case would you recommend? A, defibrillate the patient. B, immediately initiate CPR. C, apply cardioversion. and D, administer epinephrine. So exam takers for the ACCS exam from the MBRC, you guys absolutely, positively should review your ACLS, protocols. There'll be several questions there that relate to it, just recognizing various rhythm strips and responding to them appropriately, and responding to them in a little bit more insightful manner than you would for new graduates taking the TMC, the multiple choice exam from the MBRC. A little bit more about your drug dosing, certainly knowing about your cardioversion and defibrillation, number of joules and things along those lines. Sequencing, critically important is sequencing. So applied cardioversion is the correct answer in this case. So ventricular tachycardia is initially treated with antidysrhythmic drugs such as lidocaine or amiodarone. If drug management fails, or it hasn't kicked in yet, let's say, if the ventricular rate exceeds 150, or if the patient becomes hemodynamically unstable, cardioversion is absolutely indicated. Question 37. During the response to a chemical plant explosion, the RT department assigns responsibility for transporting patients according to their triage priority. Which of the following patients would you move into the designated critical care area? Okay, so A, triage priority green, B, triage priority yellow, C, red, D, black. So think back. So you're not going to get a ton of questions on disaster management, but there'll be a few of them on the exam. So just knowing some of the basics can be real helpful. Triage priority red, and let's look at what these, what these triage priority colors actually mean here. Triage priority red is designated for patients with life-threatening but treatable injuries requiring rapid medical attention within an hour. Includes any condition that compromises the patient's airway, breathing, circulation. These patients should be moved to ICU or converted to a critical tertiary care area ASAP. Yellow or green are less acute, basically more stable, and they can wait, therefore less of a priority. Priority black is for patients who are they have catastrophic injuries. So it may be, in the case of this plant explosion, they just may have, honestly, they've essentially exsanguinated, they're technically still alive. They're missing, not to be crude, but part of their head, they're missing, major parts of the body, they're technically still alive, but their prognosis is extremely grave. Those ones, not to be disrespectful, but those would not be prioritized. Red would be the ones that would receive the highest priority. 2 attempts by a resident to intubate a patient fail, and the patient's SpO2 is falling into the 80s. Which of the following actions would you recommend? A, perform an emergency cricoid thyrotomy. B, initiate a transtracheal jet ventilation. C, insert an intubating LMA, laryngeal mask airway. Please go back if you forgot your sizing for adults, 3, 4s, and 5s for LMAs, or the 3. 3 would be the smallest, 5 would be the largest, generally used for adults. So again, C is insert an intubating laryngeal mask airway, also known as a fast track. D, perform an emergency tracheostomy. Correct answer in this case, or the best answer, is insert an intubating LMA or a fast track. Let's look at why. Several options to consider in this particular case. Several options to consider. So when the ET2 cannot be properly positioned using standard direct laryngoscopy. These include increasing neck flexion, head extension, unless it's contraindicated, unless there's some sort of an injury, applying external laryngeal pressure, using a longer blade if indicated, using a tracheal tube introducer, such as a gum elastic bougie, using a lighted stylet, using an intubated LMA fast track, using optical video assisted laryngoscopy, or using fiber optic guided intubation. But notice that a lot of those choices there are not included here. An emergency percutaneous airway, transtracheal jet ventilation, cricoid thyrotomy, or tracheostomy should only be recommended if a third attempt using an alternative method or device fails and insertion of a subglottic airway cannot reestablish ventilation and oxygenation for this patient. Question 39. Patient admitted to the emergency department with a suspected cervical spine injury requires emergency intubation. Which of the following methods would you recommend for this patient? A, use fiber optic laryngoscopy or a laryngoscope. B, initiate via nasal route. C, use an illuminating stylet, and D, perform retrograde intubation. So that you can absolutely expect questions, multiple questions on airway management, difficult airway, things along those lines. If you can't tell by now, because we've already had several questions along these lines here. Correct answer in this case, use a fiber optic laryngoscope. Let's look at a little bit more of the explanation as to why. The ideal emergency method for intubating a patient with a suspected cervical spine is one that requires the least head and neck movement, also results in least potential airway trauma, and 3, provides direct visualization of the larynx. Only fiber optic intubation, inserting the tube via direct visualization over the fiber optic laryngoscope, meets these criteria. Question 40. An intubated patient in the ICU needs to undergo bedside bronch and is in need of short-term sedation. Which of the following agents would you recommend for this procedure? So before we move on with this question and answer analysis, when you're studying for the exam, I just wouldn't spend a lot of time on the respiratory meds. You guys should know that stuff, honestly. Maybe if it's a little subtle, subtle refresher, fine. Plus, because it's ACCS, you're probably not going to have a lot of questions related to DPIs. There's so many DPIs, it's maddening out there. So if you're going to be studying to be an asthma educator from, take that exam with the NBRC, yeah, you need to know those cold, and there's a lot of them. But the drugs you really need to concentrate on are things like, sedative hypnotics, your opioids, your vasopressors, your paralyzing agents. Basically the medications we kind of know, but the NBRC may expect you to know some preliminary dosing of those as well. Okay. I could go on and on. The other thing is, hemodynamics. You need to know hemodynamics. The last thing before I go on back to this question, not the last thing, but another thing is more of your discrete testing, things like BMP, things like blood lactate, things along those lines. So now back to this question. This really is pertaining to non-respiratory, but very important classification of medications. So short-term sedation, the first choice here, A, is Haldol, B is Diprivan, C is Ativan, and D is Nimbex. So hopefully you're able to eliminate D, Nimbex, because they need sedation, not paralyzed. They don't need to be paralyzed. Nothing in here that actually says that. So at least if you're kind of drawing a blank, go with what you do know, and at least, optimize or improve your chances of getting the correct answer. Let's look at why B, or Diprivan, is the correct answer. Propofol is an agent of choice for rapid sedation of patients undergoing minor invasive procedures. It has a quick and short half-life. So its mechanism of action kicks in quickly, but it lasts, half-life is less than 30 minutes. Haldol is a neuroepileptic and antipsychotic, not a sedative. Ativan is a sedative, but is used for long-term sedation. And as I said earlier, Nimbex is a neuromuscular blocking agent, not a sedative, and it really, is a distractor. It should be eliminated very quickly. It's a choice. Question 41. You note in the medical record of a patient who's receiving volume ventilation that the plateau pressure has been increasing over the last 6 hours, while the PIP levels remain constant. Which of the following would most likely cause in this case? Most likely cause of this case. Development of pulmonary edema, A. B, water accumulation in the vent circuit. C, partial obstruction of the endotracheal tube. And D, development of bronchospasm. Development of pulmonary edema, or choice A, is the correct answer. Let's take a look at why. Let's look at what's going on with this patient. Patient's plateau pressures are going up. So what's happening with that? The compliance is decreasing. So which of these answers would cause potentially a decrease in compliance? The answer is A. An increase in plateau pressure relative to baseline indicates a decrease in the patient's lung and or thoracic compliance. Common causes of a decrease in lung compliance are pneumothorax, pulmonary edema, atelectasis, ARDS. That's, again, a partial list. Partial obstruction of the ET tube, development of bronchospasm to increase airway resistance, thus the PIP and the difference between PIP and plateau would change, but would not affect the plateau pressure. Question 42. An adult male patient has a hematocrit value of 59%. Which of the following problems might this finding indicate? A, hemoconcentration. B, impaired oxygen transport. C, decreased immunity. And D, hemodilution. Correct answer is A, hemoconcentration. Normal hematocrit values for males range between 40 and 50. Some of the books will say that 40 and 48, 49. A high hematocrit, okay, as is in this case, indicates either hemoconcentration, as occurs with dehydration. So you have less blood volume. As a patient is dehydrated, there will be less blood volume. That's the way it works. And you may have the same number of red blood cells, but there's less volume. Okay. Or the volume is fine, but you have a proliferation of red blood cells, as occurs with chronic hypoxemia. So you see patients that have, moderate to severe emphysema, chronic bronchitis, CF. You see that they get polycythemic. Polycythemia is not a choice in this case, so hemoconcentration is the best response. It's a bit of a thinking person's question. 43. Echocardiogram on a 64-year-old patient who experiences dyspnea and palpitations on exertion reveals the following left ventricular data. A elevated end diastolic pressure, elevated end diastolic volume, and ejection fraction of 38%. Normal ejection fraction is north 50, 55 to 70, something along those lines. This is 38. The other thing I want to point out with this is you need to know your hemodynamic pressures. In this case, they're telling you it's elevated. In some cases, they're just going to give you the number, and they're going to expect you to know, is this elevated or not? So there's no evidence of valvular disease, intracardiac shunts, cardiac tamponade, or pericardial constriction. Which of the following is the most likely problem? A, constrictive cardiomyopathy. B, diastolic heart failure. C, pericardial effusion. And D, systolic heart failure. Correct answer is systolic heart failure. Let's look at why. Heart failure can be due to a lot of things, say that, but decreased left ventricular contractility, systolic failure, or abnormal left ventricular filling, diastolic failure. Okay. Again, those are two very broad categories. There's a lot of subcategories that would fall in, underneath each of them. In both types, the left ventricular end diastolic pressure is elevated. The key difference is that the left ventricular ejection fraction is reduced. It's less than 45%. So 45% is not normal, but it's close. It's getting close to low end of normal. And many patients can live very long lives with an EF of 45%. In diastolic failure, but normal, greater than 50% in diastolic failure. Okay. In addition, whereas the LV and diastolic volume in systolic failure is increased, causing left ventricular dilation, this pressure is either normal or decreased in diastolic failure. So again, if you're serious about taking the MBRC exam for the ACCS, I would absolutely spend some time going over your hemodynamic monitoring. And it's really going to give you a lot of key and a lot of insight as to where the pathology is in the, in the heart, in many cases, and how those changes are expressed in terms of hemodynamic pressures. Question 44. When inspecting a chest radiograph, you note that the heart is shifted to the patient's left. Which of the following is the most likely cause of this finding? A, left-sided atelectasis or lung collapse. B, left-sided pleural effusion. C, left-sided tension pneumothorax. And D, right-sided pneumonectomy. Correct answer is A, left-sided atelectasis or lung collapse. Let's look at why. The heart and the mediastinum are pulled towards areas of decreased lung volume, in particular, atelectasis, fibrosis, surgical resection, pushed away from space-occupying lesions, such as a pneumothorax, pleural effusion, and a large, lung mass. The shift of the heart position to the right would therefore be caused by either right-sided lung volume or a decreased right-sided lung volume or space-occupying lesion on the left. Of these options listed, however, only left-sided atelectasis lung collapse would shift the patient's position to the left. Question 45. Patient with congestive heart failure is receiving volume-controlled ventilation with a PEEP of 8 and has a pulmonary artery catheter in place. Again, speaking to hemodynamics, very important. Patient's pulmonary artery pressure is 42 millimeters of mercury or torr, and pulmonary capillary wedge pressure is 28. Very much elevated, by the way. Lung sounds indicate dependent crackles, bilateral wheezing. Which of the following should you recommend first? A, administer Perventil or albuterol. B, add an inspiratory pause. C, administer Lasix. And D, decrease the PEEP. Correct answer is administer Lasix. What I want to point out in the question is the wheezing is probably what we used to call crudely a cardiac wheeze. Okay. So, patients can have wheezing, obviously, because of asthma or, some sort of reactive airway disease, but they can also have it because of the engorgement of the lining of the airways with fluid and the fluid itself. So just decreasing the lumen of the airway and, causing the wheezing there. Dependent crackles are just the air moving through the through the fluid. In this case, it's transudate. Exudate would be more associated with infection. Transudate, it has to do with changes in pressures. So you have increased vascular pressures that will cause leakiness. It tends to be, thinner. It tends to have a lower specific gravity and things along those lines. And it's really just due to that fluid being forced out of the intravascular space into the lungs, and that air moving through that fluid will cause those crackles. So the whole idea is we want to alleviate the fluid that's on this patient's lungs. We can do that with a lot of ways, but they're really talking about, in this particular case, they're giving you, you got to go within the constraints of the choices. Diagnosis of congestive heart failure, increased pulmonary artery and pulmonary capillary wedge pressure, and breath sound suggests the patient has pulmonary edema. They have left, and they may have an element of right, but this is mainly left-sided heart failure. In order to alleviate the backup of fluid into the lungs, therapy plans should generally include a rapid-acting loop diuretic. So Lasix is a fast-acting. If it acts in the loop of Henle, basically, if the patient has kidney function, once they're given Lasix, 40, 60, 80, they're going to pee right away. Such as Lasix. In some cases, the beta agonists such as albuterol can be helpful because it may clear, help clear pulmonary fluid, but that's really not. That's a tertiary thing. You can consider other things such as positive pressure. They may give inotropes as well, but those aren't really given as choices here. 46, 36-year-old woman who has just undergone intestinal bypass surgery is brought to the recovery room, intubated. She has normal pulmonary function, weighs 136 kilograms, so she's big, and is 159 centimeters. In this case, they're giving you a height. So she's a large woman. She's getting bypass surgery. She's a large woman relative to her height. In this situation, you should recommend which of the following ventilator settings. A, rate of 8, tidal volume of 300. B, rate of 12, tidal volume of 500. C, rate of 15, tidal volume of 700. And D, rate of 8, tidal volume of 1,000. You can almost take D right off the plate, but correct answer is B, rate of 12 and tidal volume of 500. Patient's actual weight should be used, not their or the actual weight should not be used. The predicted weight should be. So you just need to do really the math there. She should probably be, with her height around 50 kgs. The explanation is saying. It also recommended that the initial respiratory rate be between 10 and 16. Could we argue 10 to 20? Yeah, we could, but you really just need to be using something that's much more realistic in terms of her ideal body weight. Question 47. Patient's respirations are characterized by a gradual increase and then a gradual decrease in the depth of breathing, followed by a period of apnea. This pattern is known as which of the following? A, BIATS, B, Cheyne-Stokes, C, Kussmaul's, and D, apnoistic breathing. Correct answer is Cheyne-Stokes, Cheyne-Stokes. Let's look at, so Cheyne-Stokes breathing characterized by gradual increase and then gradual decrease in tidal volume followed by periods of apnea. It's associated with brain injury. So in injury that has affected the medulla and the pons, the medulla oblongata and the pons, especially the respiratory centers. It also is observed in some patients with chronic heart failure, Question 48. Patient breathing 100% oxygen has an A to A gradient. So remember, P to F ratio, lower is worse. Okay. An A to A gradient, higher is worse. Okay. So what is her approximate percent shunt? Approximate percent shunt. A5, B10, C15, and D20. Rule of thumb. So the answer is D. Let's look at why. In estimating percent shunt, the FiO2 100%, every 100 torr equals approximately 5% shunt. So in this case, 400. So you have 4 times 5, you end up with 20%. 49. You're assisting a nurse in the ICU measure a patient's central venous pressure with a strain gauge pressure transducer. You're going to have to understand some basic troubleshooting for, for central lines, Swan-Ganz catheters, and A lines. You note that the pressure transducer is positioned well above the middle of the patient's lateral chest wall. What effect, if any, would this have on central venous pressure measurement? A, it would not affect the measurement. B, it would underestimate CVP. C, it would cause dampening of the signal. And D, it would overestimate the CVP. Correct answer is B. It would underestimate the CVP. So it's sort of the, you have the transducer that's higher. Okay. So if you're just, you just need to kind of understand this and do well on the exam, but it's higher. Okay. So if it's higher, it's going to underestimate. If it's lower, it's going to overestimate. So when measuring vascular pressure, such as central venous pressure, pulmonary artery pressure, or capillary wedge pressure, it's essential that you ensure that the base of the fluid column or pressure transducer is positioned at level equal to the point of measurement. So at about the right atrium. Also called the phlegmastic axis. Otherwise, the system will behave like a YouTube manometer, overestimate pressures, press too low, and underestimate if they're positioned too high. Oh, you can almost guarantee you're going to get some sort of a question that relates to this particular question as far as the location of a transducer and what effect it would have if it's misplaced. Question 50. Normal range of pulmonary artery or capillary wedge pressure as measured by the distal port of a PA catheter, Swan-Ganz, with the balloon inflated is A, 15 to 30 torr, B, 6 to 12, C, 10 to 22, and D, 0 to 10. Remember, pulmonary capillary wedge pressure is approximating or estimating left diastolic values. Okay, left diastolic values. Correct answer is 6 to 12 torr. Let's look at why. Pulmonary artery wedge pressure or pulmonary capillary wedge pressure normally ranges between 6 and 12. Reflects downstream pressure in the pulmonary circulation. So pulmonary venous pressure. Pulmonary venous pressure in turn reflects left atrial pressure, which ideally equals left ventricular end diastolic volume or left ventricular preload. Thus, the pulmonary capillary wedge pressure provides a window into the left heart function. So with that, I'm going to thank you for joining us for this second batch, if you will, of ACCS review questions. So there's a first batch, 25 questions. This is the second batch, and then there's a third batch as well that has actually 26 questions, the bonus one at the end there. Again, sharing with you some of the potentially helpful resources. A colleague of mine, Mark Rodriguez, and I have a comprehensive Respiratory Therapy Exam Preparation Guide. Honestly, full disclosure, it's more geared towards new graduates who are preparing to take the TMC or the clinical simulation exams. But there's some very rich information in there. And if you do buy the book, you can get online resources as well, and there's abundance of questions that are in there as well. So just FYI. I'm of course biased in terms of Egan's Fundamentals. Just has a lot of really good information in there. But also, I'm a fan of some of our competition as well, including Kettering. I've used Kettering. They have outstanding resources. They tend to be a little bit expensive, but we can point you in that direction as well. Lindsey Jones University also tend to be a little less expensive than Kettering, have some very good content as well. Please don't overlook the obvious. I'm a typical man, and sometimes I do that. I overlook the obvious, but the National Board of Respiratory Care. So you absolutely should go and avail yourself of the exam matrix, the ACCS exam matrix. They also have practice questions that are there as well. They also have resources related to when you sit for these computerized exams, and you guys may be laughing at me. Yeah, the first computerized exam I took from the MBRC was the ACCS exam. So I took most of my credentialing exams, including my RPFT, very long time ago. So for me, I made sure that when I went to the MBRC site, that I wanted to actually have some screenshots of what you're going to actually see when you're sitting in front of the computer. It gives you an idea of how to actually save questions. If you want to actually come back to a question, how you can mark it that way. Just some real kind of a lay of the land type of deal. So strongly urge you to avail yourself of the MBRC resources that are available at their site. So with that, again, thank you guys very much. Hopefully you got a lot out of this. Good luck in the exam, and have a great day.